So good morning and welcome. It's so wonderful to see so many dear friends and colleagues who are joined us here today at Vall d'Hebron. My name's Susan Feitosa. I'm our Health Innovation Business Lead at RMIT Europe. On behalf of RMIT Europe and our Executive Director, Martha Fernandez, and our generous co-host, Vall d'Hebron Hospital and its team of thought leaders, Dr. Yolima Cosio, Dr. Eva Aurin, and also Dr. Carlos Molina, we'd like to extend a very warm welcome to everyone attending today's seminar on building value in healthcare. We'd also like to welcome and thank our speakers from Telefonica and IUMED for joining us today, and we're really looking forward to having a great and dynamic conversation about what we mean by value in healthcare. So before we get started, we have to do a few housekeeping items, so a few reminders, and I just want you to look at the Twitch. Okay, so now I'd like to introduce Dr. Olga Koksagina from RMIT's Graduate School of Business and Law and a Vice Chancellor Fellow who will moderate today's event. And I want to tell you, Vice Chancellor Fellow means that she's the cream of the cream from RMIT. And she's going to moderate, and I invite her to come up. Olga's background is in innovation management. She also has specific research areas in strategic management of design, open and radical innovation, and entrepreneurship. And she's she's passionate about healthcare. So Olga, I'll pass it to you to begin the event. Thank you.
Okay. Hi, everyone. Thanks, Susan, for introducing me. So before we start with this challenging topic, and we know that value-based healthcare and value-based processes are really hard to accomplish, and we have an important issue to discuss today on how procurement can actually help solving some of these issues. Before that, I would like to know you a little bit more. So we have this interactive tool, and I would like to ask you, first of all, where are you coming from? How you are connected to healthcare? Are you a healthcare professional or IT specialist or procurement or perhaps others? So we know you better and we know why you are here in the room. Well, thanks for doing that. And without any further notice, I would like to introduce our host and our first speaker, Dr. Yolima Cosio-Gil. Well, many of you, of course, know Yolima very well. She's the Director of Information Systems at the Vall d'Hebron Hospital, and she leads a multidisciplinary team of experts in IT systems, doctors, nurses, pharmaceuticals, epidemiologists, and statisticians. Well, we can surely say that her experience is intercontinental because she had worked across different places like Southeast Asia, Africa, UK, Colombia, Spain, giving her a truly international experience in private and public-private work.
What is the preference of the patient that can speak with the patient, that can go further to just prescribe a pill. So to do this innovation, we are focusing 4 areas of transformation. One, of course, is the patient, in the patient outcome and also in the patient experience. Also, go to the citizenship and see other models to go to the normal population, start to implement also prevention. Another key point is the care integration. The best place where the patient are is at home. Most of the patients say that. There are different preferences. Always focus in what the patients say. But the models of hospital at home are the future. Also, the interdisciplinary clinical groups. We not working anymore as a silos. We need to work together because if we focus in the outcomes that matter to the patient, the outcomes are not a result of a single doctor or a single nurse or a single department. The outcomes are the result for all the process of the attention of the patient, including primary care, including the hospital, including rehabilitation and social care. Also, motivation of the professionals. We cannot do that without you, without the professionals. The professionals need to redesign the pathway of attention with the patients. Need to identify where are these areas where we need to improve. And they have to have the leadership to do all these things. And also discover new role of professionals with all these new technologies, with all these ideas to hear the patient, to decision-making, sharing We need to include social science, data science, and other kind of profiles in our teams. Of course, we focus on efficiency and sustainability, generating value with the information that we have and trying to gather more information, and redesign also physical environment, both structurally and functionally. I like this slide because what I say is, if we want to focus in what is value in healthcare, we need to work with professionals. We need to hear the patient, the family, and the society. We cannot take decisions without knowing what is value for them. We need to collect the outcomes that matter to them. Professionals have to have these outcomes in the day consulting rooms and take decisions with the patient. We need to work with the supplier. We need to work with the government. We are working in innovation procurement system, and we need to hear and to work together. What could you offer to increase this value to the patient? And of course, like with RMIT, we need to work with educational institutions that also give us an idea about how to do this process of attention and this specialized that we need in the best way. Because we really believe if the patient wins, all of us will win. Government, policymakers, payers, providers, suppliers, pharmaceuticals, health educators, patients, caregivers, facility staff. Could you imagine all of us concentrate in that this lady will go to the top, that the top of this step is like the best health that she can achieve at this moment? So I don't know how the legend of the elephant finished. I have heard sometimes that the blind science start to distrust the other ones because they think that they're not telling the truth. I want to think that the blind science go around and have a 360 touch of the elephant and see the different point of view. And with that, they sit together, they put in common, and they achieve the real picture of what is an elephant. So that's why you are here. I want you to invite to construct all this definition of value, to build the definition of value, to work together for that in the healthcare. Then welcome to all of you, and thank you very much to RMIT to make that possible. Welcome.
Thanks, Yulima. Just as I mentioned, we're not going to take questions right now, but if you want to post any of them, you can always use menti.com, and we are also going to take some questions in the audience later, and think of questions for Julio as well. So with that, we've seen that one of the pillars for better value in healthcare are suppliers. And with that, I'm really happy to introduce Julio Jesus Sanchez, Head of Digital Health Operations at Telefónica Spain. Julio has a really impressive track record on basically leading project teams in charge of digital transformation in healthcare. Thanks, Julio, for joining us.
Morning. In the first place, I want to thank the organization of this event, both RMIT University and Van der Bron Hospital for inviting us to share our vision about this topic. My presentation will be mainly about digital transformation of healthcare and how this digital transformation can help healthcare providers in order to increase the value they provide to the patients. In the first part of the presentation, I will try to center the topic and talk a bit about sustainability of the system and patient experience. And in the second part of my presentation, I will try to show you some practical examples on how some healthcare providers are changing the way they provide these services, introducing the digitalization in their work. First, the challenge ahead. We think that in some way, healthcare industry is in the middle of a transformation. And this transformation is fueled by two main forces. One of them is sustainability. In industrial countries, we see how baby boomers are reaching their older years. What is generating this? This is generating a more high-cost patients in the system. And this, obviously, must introduce a budget pressure because we have to provide more service to more people with the same resources. But on the other hand, there is also a change in the patient expectations. We think that the patients that we have today are asking for us for healthcare services not in the same way as they did in the past. Why? Because we are experiencing what we think is the shift to the digital patient consumer. And why happens this? Because patients, of course, are not only patients, they are people too. And as people, they are in contact with other companies, institutions, where a higher degree of digitalization is being taking place, higher than in healthcare industry. So what they ask for us is a similar degree of digitalization that they are experiencing is, for example, banking or tourism. They want more simple, flexible, and easy-to-access services that in some way they are now getting in other places. And if we don't change, if we don't start to provide these new services, such a gap is going to arise between healthcare professionals and patients. For example, some polls said that healthcare professionals are no longer the main source of information for patients about their conditions. Why? Because they live in a world now that is full of information, both through internet, apps. The information that are in the hands of the patient is quite big. So the point is that if they don't have a continuous and frequent access to a validated source of information from the system, they're going to lose themselves in perhaps internet, perhaps this problem of the fake news that we are all suffering. But it really can digital transformation help to solve this problem? What is in really digital transformation? You can find several definitions out there. I like this one, that is see digital transformation as a makeup of different stages. Stage one is about the digitalization of processes, but for sure this is not something new. Digitalization of processes has been with us for a long time. It's the common responsibility of IT departments. What is different in digital transformation are the rest of the stages. In stage two, we see the user experience, the digitalization of user experience. And we are all experiencing this user experience digitalization in our common relationship with other agents. But in stage three, we find what is the creation of new services that are native digital. And lots of companies and institutions are working in the creation of this new breed of digital products and services. In stage four, far away, you have these companies that are implementing a pure digital business model. You see how other industries as logging or transportation are suffering from the upcoming of these companies as Airbnb or Uber, and they are transforming the whole industry. But the point is that we think that now in healthcare, where there is more field for improvement is in the stage 2, in user experience. Why? Think about the patient. The patient comes to the health center, to the hospital, to the clinic. And well, here is where the magic happens, okay? But it's not the place where the patient spends the most of its time. At the clinic, at the health center, a lot of things must be done with the patient. Of course, what is typical symptom understanding, exploration, diagnostic, prescription. There is also here at the hospital of a lack of time in order to do things as empowerment of the patient, our training of the patient, as give the patient resources to be consumed at home. What happens at home? At home, the patient usually have doubts, anxiety. Sometimes they think about returning to the clinic in order to solve part of these doubts. The lack of adherence is a common problem of every prescription. There is a lot of unguided internet searching, and as I said, patients are exposed to health fake news if they don't have any kind of guide. So I think that here is where digital transformation can help with the concept of remote intervention in order to put into a frequent contact the patient with the system. Through technology, of course, but technology is not the main part. The main part is to establish a contact in order to guide and resolve the doubts of the patient when it is at home, and it can be guided in some way. We think that there are 3 axes of improvement in this kind of remote interventions. Of course, the patient experience can be improved and reduce anxiety and perhaps get a better adherence to the prescription. But we think that there is also a scientific evidence that this kind of remote intervention can generate an improvement in the health of the patients. And on the other hand, if we talk about the system, we think also that efficiency could be improved in the sense that as healthcare providers, we can provide more services and better quality service with similar resources. So this is key in what is our strategy, Telefónica strategy in connected health. We are working in create this more connected, collaborative health open ecosystem. The point is try to fulfill not only the demands of transformation of the system, but also put the patient in the first place and be able to fulfill also its demands. From now on, I will try to show you some examples about what we think is digital transformation. The first one is an example in stage 2 of digital transformation. It was Atlantic Project. Atlantic Project was a clinical trial performed by Andalusian public healthcare provider in collaboration with Telefónica. We are talking about 5 hospitals, a total of 510 patients. They were patients with advanced heart failure and chronic respiratory failure. Mainly, we are talking about high-risk patients, followed up by internal medicine departments. And the comparison was between a previous usual care for these patients and a shared comprehensive clinical care plan that was implemented both with and without telemonitoring of the patients. We provided, in this case, a remote patient monitoring platform with some devices in the hands of the patients in order to take measures as pulse, glucose, weight, questionnaires, and video conference. What was clear, something different in this project was this shared comprehensive clinical care plan. Patients were at home, discharged from the hospital, and no matter in the treatment group or in the control group, they generated some alerts to the system. In the treatment group with our platform, and in the control group through phone call. The point is that at the other side of this alert was the Public Andalusian Health Call Center, Salud Responde, that they did a risk stratification of the patient in order to put into action another fourth health and social organization of the system. Perhaps they could create an appointment at primary care or an appointment at the Department of Internal Medicine, or put into action the health emergency services. And in case of adherence or solitude, they could put also public Andalusian social services to have a contact with the patients. We don't have the final results of this clinical trial yet, but we think that the provisional ones that we have are quite good, mainly in comparison with the previous situation. This type of stage 2 solution of remote patient monitoring is something that has been with us for some years now. This company, Tanstal, is an international company. Telefonica, we have now a partnership with them in remote patient monitoring, and they have experiences at the scale in other countries, as for example, this one, TF3 Consortium, in Northern Ireland. We are talking about a service covering a population of 1.8 million people with an average of 3,500 patient monitoring sites per year with good results. So this is not quite new now. We have these experiences. They have been proven at scale. It's something that is available and can be put into action. Changing a bit, this is another experience in the stage 2 of digital transformation. SaludSpot is a company already closed, but it was a first attempt to create a remote procedure model outside of the usual healthcare provider network. It was a company providing a healthcare advice service through internet. It was anonymous and free of charge for patients. And on the other side, healthcare professionals, it was such a kind of freemium approach. As I said, this company is already closed. It was invested by Telefonica, and perhaps that was part of the problem, okay? It's hard sometimes for a startup to be invested and perhaps managed by a big one, okay? But I think that it was quite innovative, and it's the way we must think about B2C models in order to reach the patients. Remote consultation. Remote consultation is something that is clearly on the rise. Pages and pages of digital media are being covered by this experience in the United Kingdom that is Babylon GP at hand, provided by the NHS. And here at Spain, we have this company, DocLine. We at Telefonica, we have also a partnership with them in an insurance customer. I think that is something that is being tested both by private and public healthcare providers, and it's something that we will see as more and more as a common practice in the future. Changing the stage, this is not a stage 2, but a stage 3 experience. We are talking now about a new company that is Sevilla. It's a spin-off of Mapfre insurance company. And what are they doing? They are deploying a new breed of healthcare digital services, native digital, trying to provide a new way of give an insurance service, but mainly through technology. They put the patient experience on the first place. This is the philosophy, how they are trying to increase the value they provide to the patients, creating this new model of pure digital services. And we will see in the future more things similar to these ones. New B2C models are being tested, and this is why, because the most of them will come from the technology worlds, where several different business models are used, as for example this one, add-on, bait and hook, freemium, subscription. We will see how companies and providers will test this kind of solutions. This, for example, is another young startup, TA.care. They are offering a free doctor-to-patient cloud communication platform. Well, it's an experience probably based on advertisement, but the point is that we can wait lots of these experiences. Some of them will fail, some of them will succeed, but in any case, they are going to give us clues about how healthcare providers must think about their future. And in my presentation, what we think is that we are, of course, in times of change, of deep change, really. But of course, these are also times of opportunity. And I think that the best we will be able to say in the future is that we leave things better than how we found before. That's all. Thank you.
Thanks, Julio. I know that it's getting really hot in the room. We're switching back the air conditioning, so it will be better. And we will start with the panel discussion quite soon. Before we start, are there any pressing questions for Julio? Comments? Okay, we'll have an opportunity to discuss it during the panel. So with that said, again, I will put back the screen with the questions later on, but if you want, you can also post your questions on menti.com, and we will be back to them during the panel discussion. So our panel for today, and we've heard two perspectives, of course, on value in healthcare, especially in the public hospitals like Vall d'Hebron, and then the procurement side and all the amazing projects we had in here. And now I'm really happy to introduce our panelists. So you've met Julio already. We have Eva Orin Padro. So Eva, many of you might know her as well. So she's the head of innovation and e-health at Vall d'Hebron Campus Hospital. Please, if you can join us, and Julio as well. Sorry to move you around, guys, but still. So Eva has a bachelor in chemistry from the University of Barcelona and an international MBA from La Salle. So both health and business perspective in here. We have Molina, Dr. Carlos Molina. He has an outstanding track record on basically having more than 525 peer-reviewed publications, which is amazing. And he is the head of the stroke unit at Vall d'Hebron. We have Xavier Yoga. CEO and co-founder of IOMED. So IOMED, you will explain us what IOMED is all about in a couple of seconds, and you know Julio already. So as you know, our panel will be on value-driven healthcare. Before we start, let's please, I'll give an opportunity for our speakers that you don't know yet to introduce themselves. Please, let's start with Carlos. Yeah.
Thank you very much. So I'm Carlos Molina. I'm the head of the stroke unit at Vall d'Hebron Hospital here in Barcelona. It's my pleasure to be here and share with all of you our experience on value-based stroke care, focus on stroke, that we started like 2 years ago, very successfully, in improving our process of care, reducing the time for reperfusion, and all the no value. We took out the no value from the process, and we improved the process itself. And as a result, we improved the long-term clinical outcome of the patients. And also, we collect systematically the outcomes, not only the traditional outcomes like the ranking scale, which is very inaccurate measure of the outpatient outcome, but also the PROMs. It means the patient-reported outcome, that is what is valuable for the patient. And we integrated the whole, all this information, giving us 30 and 60, 100 degrees vision of the problem. So we learned a lot in the last 2 years, and we are happy to share all this gain that we had in the last 2 years with all of you.
Okay, thank you. Eva?
I'm the head of the innovation unit here in the hospital. I'm collaborating very close with the BIR because it's another part of the campus that it's very important for the innovation. It's different innovation, but are very linked with our innovation. And I'm collaborate these 2 years more or less with Carlos in this interesting project about value-based healthcare. And I think it's the way to improve the treatment for patients, to ask for patients what is your value, what is for you the value. I think it's a very interesting project, and I think the next years is a method that it increase in the other hospital, but I think it's a future.
Okay, thank you, Eva. Javier?
Sure. So I'm Xavier Yoga. I'm CEO and co-founder at a company called IOMED, based here in Barcelona, actually. Thank you very much, actually, Olga, for inviting us, and also Eva for including us in this panel. It is a pleasure to be here. Our company is all about data, essentially. We work with data coming out of the hospital. So you might be wondering, why is this guy sitting in this panel, actually? So here my colleagues are all about the what. What is the value? Where is the value? I'm all about the how. How do we measure the value? How do we see that value? So going a little bit back to Yolima's legend about the elephant in India, which is very useful for me right now. I'm the company, I'm the technology allowing you to see that elephant. So I'm the technology allowing those blind doctors to not be blind, let's say, in that legend. How do we do this? So we apply artificial intelligence in a very particular way called natural language processing, in Spanish, procesamiento de lenguaje natural, for all of us. I'm sure that's easier for you to follow. So we apply natural language processing on medical records to find all that which is clinically relevant in that medical record, structure it and prepare it for it to be measured, for it to be used in an analysis. So essentially we create data where we usually had just text or medical records in a, let's say, more disordered way. We organize all the information, all the medical content of those medical records into a database that we can then use for many different uses, amongst them to measure exactly what value is, where the value resides, what the exact repercussions of a particular activity has had on patients, etc., etc. So actually my presence here in the panel actually is all about how do we find that value, what data do we use to measure that value, how can we help you guys to find that value and find those activities to bring more and more to our patients.
Okay, thank you. So as you can see, we have a really balanced panel with two people who represent the what, why are we doing that, what do we need to do, and then the two other perspectives from basically how can we actually do that, How do we collaborate with the hospitals in order to deliver a better value-based healthcare? And we did ask our audience today on basically what are the biggest trends in healthcare. So I will return this question to you as a start, and basically from your perspective, you are in there from two different sides. So what are the major trends that will impact the healthcare tomorrow? Perhaps just one trend from each side. Julio, if you want to start, yeah.
Well, if I have to choose one, I think that the integration of the different levels of care that we provide to the patients, and not only those related to healthcare, but also those related to the social care of the patients, it's a key tendency that is going to change in some way the way we provide the service to the patients. So the other one, perhaps I have talked a lot about digital transformation, but I think that this integration of the different roles of the different people that are taking care of the patients, it's key now.
Well, I think is the main goal is we have the technology, we have the resources, we have the information, we have the, tools to explore this information as well. What we don't have is the critical part is the patient motivation. It's easy to say to the patient, you have to do this for 2 months, for 3 months, but after that, he has to take care of himself. So we have to empower the patient. This is critical, and this is not easy. It's not an easy task. It's not easy for sick patients, for patients who have suffered a stroke, for instance. It's even much more complicated for still healthy people, for primary prevention. So it's difficult to encourage these people, please take care of yourself, empower on your health. How are the tools that we have to make it easy and social in some way that is well seen for everybody, that you are a guy that take care of your health. This is good. It's a good to start. Sport, making sport, for instance. No? You have to exercise yourself, because that the slide that you show, very nice, that you at some point at your age, you start thinking that you're going to be a patient one day, sooner or later. But you have to think about it and carefully take measures to do this. And we have the technology. So we have social networks. There are ways to make the healthcare social in some way. So they have to feel that. So this is our perception after 2 years of value-based care. It's not a matter of coaching. It's too much coaching. We have interviews. We have a lot of information from patients. We receive all the prompts that they think about us and so on. But at the end of the day, they are more linked to us. They are not independent. They are more dependent. And on the other way, some people think, well, I fully recover, so I can live my life again as before. And they just reject to take the medication anymore, and all the problems start again. So this is, I think, the main problem is now how to motivate patients to be engaged and how to empower the patients for healthcare.
Okay, thank you.
Yes, I think that one of the most important trends now, at this moment, and you can see in all the hospitals, I think it's how to involve the patient in their treatment, in all the patient journey. It's important that the patient ask what are their problems and explain us what are their goals, what they need. And it's important that they be part of a multidisciplinary team to construct, to build new solutions, technology solutions, to improve their health. But without them, it's impossible to construct a solution that improves their health, because they are the center. But it's important that really the patient is in the center. But it's very cool to put in their slogan, the patient is in the center, but really is in the center? No. And nowadays, any hospital, I think, has really the patient in the center. And a very important trend now, it's real to involve the patient in all the patient journey. I think it's very, and the technology is a tool, but it's not the most important thing.
And Carlos, I mean, we know you mentioned these 3 years of basically implementing the first at Vall d'Hebron project on value-based healthcare. And basically, we were just wondering, I mean, patient at the center, social innovation, how basically we can motivate these people. Can you please share your experience of basically what did you achieve so far and what was the biggest challenge perhaps of doing that?
We didn't achieve this goal, actually. So we're trying to. But, well, first of all, we'll start collecting all the information, all the prompts for at day 7, 3 months, and 1 year. Even the cost, the indirect cost of a stroke. Not only the direct cost, that we have the cost, we have also data of the indirect cost, including rehabilitation, social care, and all this stuff that is around the patient. But sometimes the relative of the patient has to work just half time to take care of the patient, so this has to be counted as well. So the prompts that we get from the patient help us to understand, as Eva says, to understand the problem. So there is much more than clinical deficit, neurological deficit. There are depression, social barriers, language barriers that change the life of most of our patients. But how to encourage them? So we have a program that is called Farm Alarm, that is like a coaching program. It's a cell phone program that help, a smartphone program that help the patient fulfill the medication and take the medication properly. And we know exactly when the patient takes the medication or not. But we are reinforcing the idea of coaching a protective, not proactive medicine. Probably is not the proper way for the future. For a few months, it's okay, because the patient learn a lot about how to take care of himself. But the problem is at long term, at long run. This is a problem. So we need to have a transition of how to teach the patient to take care of yourself, not need us anymore. So just to take care, because this is around forever. You are a patient forever, not just for 3 months. Not you are free from disease. You have risk factors. You have to take care of your risk factors and control properly your risk factors. And you mentioned some technologies that nowadays are very useful. So all we have blood pressure monitoring or remote monitoring that can be very helpful, but in some way they note somebody's watching, somebody's controlling. And we have just alarms. And this is very fruitful and good for the health system to avoid many visits a lot of visits to the ER that are nothing. I think that can be solved easily, but by interview or even a chat can be easily solved. So.
Amazing. Maybe a quick follow-up question for you from the audience. Basically, which kind of methodology did you use at the stroke unit to eliminate non-value processes? Yeah, sorry.
Well, the methodology what we use, where is Maria? Is around. So it's in the audience. It's in the audience. Yes. So she's technical process. She developed. When we started the process, we were selected in this hospital because we're supposed to be well organized, and we realized that we didn't. So at the end of the day, we start with a meeting, the whole team, including all the professionals that are involved in the stroke care, not only neurologists, nurses, social workers, rehabilitators, and also primary care physicians, patients, and relatives, just to organize and see what is the current status and what is the next step, what are the desires, for instance, from the patient point of view. And this was the start point. And then in the hospital, the process in the hospital was improved, identifying the no value, all delay, causes of delay in treatment or visits or whatever was solved using technologies as well that we have in our hands. We used to use WhatsApp, and WhatsApp is illegal to put in patient data. The patient blah blah is coming in 10 minutes. No, this is illegal. Or take a picture of the patient sticker. This is illegal. So we have now a system that we have anonymized patient data is anonymized, and we have the imaging, the CT scan, MRI, and all the stuff is anonymized, and it's not in your particular cell phone. It's in the cloud. So this is a cloud-based approach, which is more clean from the patient. We learn a lot about it. We solve this problem. We improve the process. We shorten the door to needle. The time it means the time from patient's arrival to the hospital till start the treatment. For instance, the thrombolytic is a treatment for patients with a stroke. It was 26 minutes, now it's 16 minutes. So this is just 10 minutes, but it's a lot. For the brain, it's a lot of time. So we improve the process that way, just improving the communication among the professionals.
Yeah, thank you for that. And of course, we see, and you mentioned yourself that the role of technology is really important, the apps that you've developed, the data that you are collecting. How do you, from the data perspective and digital transformation perspective, do you see the better value inclusion in healthcare? Perhaps not even today, but in the future. I don't know, Julio or Javier, who wants to start?
So I think data as such is just one among others of the many resources we need to use in this field. So in the near future, actually, and luckily I'm able to say that's already in the near future, what I see is that one of the biggest trends in this sense will be to maximize the use of this resource. At the moment, it's potentially one of the resources that we have available that is less used in our daily activities, both at the daily practitioner activities as well as in the daily research activities, or in not so daily but also very relevant analysis. We have a lot of information. There is a lot of information being daily generated in hospitals, in primary care facilities, in other environments, such as, for example, generated by the patient himself or herself. But we're not really using that information. That's so one of the things we will see for sure in the coming years, hopefully even in a shorter period of time, is an increasing use of this data for many different particular use cases. And I can point out clinical research, I can point out process reviewing, for example, I can point out quality analysis, internal studies in hospitals, and there are many other potential use cases for this kind of information. But the thing is, we need to start understanding that there is a lot of value buried in that, in those data, in that resource, and that we need to start actively exploiting it from right now. That said, it's what we can offer is just data. We need to do that in cooperation with you guys, because I can offer data, I can offer a lot of data potentially coming out of Vall, but I need to know what for. And that's the key point here.
It's critical because, let me add something. Yeah, this is critical because the main challenge is how to deal with unstructured data. Mm-hmm. The structured data is easy, it's in database and you can exploit it. And how to generate alarms, for instance. If I have a patient, for instance, admitted in my stroke unit, before discharge, I have an alarm, but based on the artificial intelligence software, I have an alarm. This patient has a 78% risk of myocardial infarction in the near future, based on the clinical grounds that we missed just because we are focused just on the cause of current admission. So I think there is a lot of room for improvement, for not only research, but also clinical management of patients.
Application and empowering
Absolutely.
patients per se for
Absolutely.
the prevention side
Absolutely.
as well.
And a double check before discharge. I think it's important.
And I'm actually very happy that you mentioned the unstructured part of the data, because actually when you start taking an actual look into how the information is prepared in a hospital, you potentially have by far the majority of the interesting stuff buried inside text and unstructured sources.
That's the problem.
And that's a key point here.
Yeah.
From other point of view related to data, there is also a great potential in mixing the data that comes from the hospital, the data that we come from the system, with all different sources of data the patients are generating out there. Because as we say, patients are not only patients. They are people, and as people, they are generating information all over the world. So if we mix the pure clinical source of information with the other sources of information, more insights can be get from the patients.
And we know that basically mixing different sources of data is, of course, beneficial, but really tricky and really hard. And then brings me to the next question from the audience on basically how do you think the regulation is supporting that? What do we need to do in order to actually support digital healthcare and data management? Is it ready?
Okay, I will address this from the point that directly touches me. It touches us actually when we collaborate, which is you probably all have heard about the GDPR, don't you? About the new GDPR. What is the GDPR? If I ask you about a particular regulation within the GDPR is, let's say, a framework within which we can play and use this information for this or this or that purpose. The intention of the regulation, of a regulation like the GDPR, is to set up a frame in which we can play. Sort of, this is the area where you can play. You cannot go beyond these boundaries. What is the main point where this regulation is lacking? I'm trying to answer the question particularly. It lacks a little bit of concretion. It needs to be a little bit more concrete for the uses we're going here. You've probably all heard that technology goes faster than regulation. Haven't you heard? That's the classic thing that we say at the startups. Anyway, what we need to push, and this is something that companies cannot do alone, we need to do that in collaboration with public institutions, in collaboration with professionals and experts. We need to push for these regulations to adapt and to be more concrete in those cases we are interested in using. For example, we need GDPR to be very precise when it comes to clinical research, and it is not. We need GDPR to be very precise when it comes to the use of data for clinical management, and it is not. We need this kind of precisions to happen in order for our regulation to be really, truly adapted to these changes. And that's what I'm asking here is not easy. It needs to go fast, but it needs to happen. As long as it doesn't happen, my answer to this question is no, we're not yet ready.
And I think it's not only, as you mentioned, it's not only to be, regulation has to be concrete, but also has to be flexible and rapid, quick. Otherwise, we lose competitivity. Yes, we have to be able to compete to others at the local level, to other scenarios. At the same time, we have a regulation has to protect the patient data. The patient first, the patient has to be well protected, but we have also the regulation tools to protect the patient. It's there. It's continuously used for clinical trials and for all the research. But for this, for new technologies that we want to apply in patients, I need this flexibility for regulators.
Yeah, and you mentioned, of course, collaboration as an important part of basically how do we as hospitals collaborate with external actors in order to implement this technology, where basically purchasing is there. And we all know that purchasing is not as flexible as we would like it to be. So from the perspective of the hospital, what are the challenges that you have in order to collaborate with the external providers? And from the provider's perspective, how do you do it with the hospitals? So perhaps let's start with Eva. Yeah.
Yes. Well, I think in Vall d'Hebron case, we are very flexible with collaborating with another stakeholders, as a startup, as IOMED or Telefónica, big and small companies. And I think perhaps we are public sector. It's very complicated for us to purchase all that we need because we don't have money. It's the reality. This is the situation, and it's very important for us to do this type of collaboration that we have a relationship win-win, and they improve new technologies, and we can improve this technology in our hospital and to make better different solutions to improve the healthcare of the patient. But for us, it's a key piece to do innovation in the hospital, because with our money, it's impossible to do all that we can do.
Okay, clear. And
On the other hand, I think that related to the regulation, there is field for improvement, mainly in what is related to public innovative purchase. That is a field really to be developed, because we have the concepts perhaps from 10 years ago, but it haven't been carefully developed in the reality and put into action in the public purchases.
And how do you see it? How would you define the innovative purchasing? What would have to change?
Well, there is a definition in the current law, but the point is that from the definition to the practical use of this public innovation purchase, there's a long field that it really haven't been uniformly covered right now.
I have to add a perspective from a small company. Because here, my dear friend Julio, you can afford to participate in different processes that are designed for large corporations, in many cases. So, for example, let's think about trying to sell something to a public institution like Hospital Vall d'Hebron, for example. If we try to sell something that exceeds a certain amount, we have to go through a public tender. And that is a path that is not necessarily designed for small companies. So that's a path of selling that's completely excluded, or the other way around, completely excludes an organization like mine. What I'm trying to say here is I'm a big fan of collaborating with Hospital Vall d'Hebron. I've been doing that for several years now. I think there is a lot of room to improve, make things faster, to organize different teams in a more efficient way. Not particularly here in this house, but generally in many public institutions. But what we really need, and I think, and I'm very optimistic, we have first insights that things are moving towards that. We need channels for small, quickly evolving organizations like mine to access public organizations like Hospital Vall d'Hebron, for example, or other hospitals in which we actually really need to validate our technology. We need to be here. We cannot exist without collaborating with you guys. But I'm very optimistic on this side. I'm seeing first insights, first points that point towards first channels being opening in this sense.
Can you provide an example of a channel that is opening?
I wouldn't like to get too precise because it's nothing that's already happening, but there are ways of companies like mine to join partnerships with public organizations, not necessarily going through public tenders, for example, or not necessarily going through innovative public purchasing. There are areas, but I wouldn't dare to say something particular at this point.
Okay, thank you. Please still keep asking questions. We will come back to them a little bit later. Before that, Eva, you mentioned that it's a public hospital. Money is an issue. And we know that across all the states, the budgets are getting smaller, but technologies are getting more complex. So what would be the alternative streams to actually fund these procurement solutions? Do you have any suggestions or ideas?
No, I just want to add that there are channels, pathways, that are just limited, for instance, for European funds or public funds, not for private enterprise, or at the local level are very limited, and we have to join partnerships and so on to apply to this. So in terms of validation and calibration of the methods, what we do is we start in our hospital and then we expand to a network that we have in Europe, in 10 European hospitals in a league, that we are part of this league. And this is like a platform to apply an external validation of any method that we test first here and then in the other part. But we need funds. And these funds can, if you are part of this network, it's much more easy to get these funds. Otherwise, it's complicated, as I mentioned.
Yes, and we have different ways to make this, to have this money. For example, the 2020 grants, the CPI, the FEDER. There exists a lot of ways to gather this money, but it's complicated. It's not easy to win this grant.
If you have a good
It's
idea and a
complicated.
powerful project, you can get it.
But it's complicated. It's complicated, and the time it's not.
It's
It's not.
long.
It's
It's
long.
long.
And
That's right.
the technology is very quick, and it's impossible to. It's faster than the proceed, and it's complicated to have a technology that you need now, and you need to do a call to. ¿Cómo se dice? To apply on a call. It's complicated to have this money now. Yes.
I mean, there is a lot of funds and a lot of channels, a lot of calls for different innovations from the European Union. We also have some local initiatives as well in the Spanish government, the Catalan government. What we need, in that sense, I think that the public side of the funds, I would say it's pretty decently covered. It is long, it is difficult, that's correct. What we need, where there is a lot of room for improvement, is in the private side. And you already commented on collaborations, and I totally agree. What we need to do is a second chapter, which is normalizing this collaboration. And there I'm trying to be a little picky, because there are particular industries that are not necessarily well regarded. And when it comes to collaboration with hospitals, I won't name anyone, but there are particular industries that don't necessarily have a good naming when it comes to making a collaboration public. We need to, in this sense, educate both companies, professionals, the public in general, that the fruit of those collaborations is always intended, or should have an end impact on the public interest. Although there is a collateral win-win business interest implied, we need to educate the public and everyone implied in the process that this kind of collaborations are actually healthy and are actually to be promoted in the future.
Maybe what we need is a blockchain approach.
That's very interesting.
Yeah, that's right. And having for instance, for the primary prevention, with this approach, we have a tokenization. This is 6 tokens, and 2 tokens is for the government, 1 for this company that is interested in this part of the process. So,
We should make this.
Yeah.
We should make this.
Okay.
And indeed, we can see, we see a lot of blockchain appearing to data sharing in the health practices. And I mean, one of the alternative sources for funding can be also crowdlending. Why not actually use some of the crowds to actually invest in some of these technologies in the first place? Coming back to patients and adding a little bit more complexity. I mean, we talk about collaboration with procurement, but once we bring patients in there, and we know that in order to work on value-based patient healthcare, we do need to collaborate with patients. So what are your current challenges, or how do you actually organize that when you need to involve patients in clinical trials or research or?
So involving patients in clinical trials is not that complicated. They are very familiar when they come to this hospital that we offer for most of our patients different kinds of clinical trials and follow up them. They don't feel like this is an experiment. They feel that they are offering me something else that is good for me, and the follow up is going to be very carefully, and they want to watch for me. They are very convinced of that, and we have no problems for clinical trials.
Digital solutions are involved?
Digital solutions are involved in this nowadays in clinical trials for the follow-up, not only for randomization, but also for the follow-up. And we use apps for some of them. We use PharmaLab, just started with this app, our app, which is PharmaLab, to follow up the patient, to call them just to make sure that he takes the medication for the trial, which is very important to avoid this drug discontinuation. And it's very easy, and it's handling. You have to it's like in nowadays, most people in the 40s, 60s, 50s, and 60s, they use smartphones. They are very familiar on that. It's easy for them to, yeah, this is an app, just download the app and follow the instructions. That's it. It's that easy. It's not a barrier, I think. Even for old people.
Well, 60 is not all, but yeah, okay.
No.
Okay, other thoughts?
I think,
Oh, yeah.
sorry. I think that we don't realize how quick patients are changing. We continue thinking about, okay, the typical patient that comes to the hospital and perhaps it can be afraid about technology, about technical, but this is no longer outside there. The point is that now patients are quite far ahead from us. And really they are asking us to change the way we do the things. It's not the opposite.
Actually, there are several approaches to improve the patient's care, including the gamization, using the what's the name of this? Candy Crush.
Oh, yeah.
My mother is a champion of Candy Crush. And if you jump into a bus, see the old people, they are playing Candy Crush. And there's a way how to better control, for instance, the glucose control based on the points that you get on Candy Crush. There are some solutions that help the patients to motivate themselves to be.
Yeah, and we see an increasing use of gamification in general. Yeah.
Yeah, absolutely.
And I think they are very interesting to test these technologies because they know that it exists. And they are happy to test because I think it's the future that use this kind of technology, and the patient is happy to know that in the hospital they can use these technologies to improve.
Actually, for them, it's funny. It's different.
And
They want to be involved.
And for caregivers, not only for relatives, friends, caregivers, it's not only for the patients.
Yeah, definitely. And well, basically it brings me to a question that I'm going around to bring it back. So basically, do you have at the hospital any lab unit to actually do this kind of projects?
So we have the Tictus. Tictus is a lab.
Okay.
Tictus. Tictus. And we develop all these solutions in partnership with other companies for 2 years now.
Okay, interesting. And yes, please.
Can I do a question?
Yes.
We do have technology. Sometimes it's better to do it quickly.
Yeah, I also mentioned that you can jump with the question from the audience. So yeah,
Sure.
Go ahead, and you have a micro on your. Yeah.
Okay, thank you. Well, first of all, thank you very much for the presentators, for the organizers. I would like to ask you, to you all, and even to the audience, if you have been using behavioral economics for this kind of processes, because I am a behavioral scientist and I'm doing this kind of things. Actually, I'm starting a research project with people with hypertension. So maybe this can help you a lot in those you, Carlos, and you, Eva, were mentioning about engagement, involvement, and so on. And if it is the case, what you have been doing, or what are you doing with this approach?
A project which is called Stroke Care Economics. This project is for those patients who are candidates for reperfusion. Reperfusion means open up an artery in the brain, which is blocked by a clot, and you have to put a catheter and take out the clot from the circulation. This is reperfusion. And the time to reperfusion is critical. So we changed our model of care, our process of care, with some new technologies just to improve the communication and improve the transfer of patients directly to the angio suite, to the catheter lab. From the ambulance to the catheter lab, bypassing the ER, bypassing all the staff, all the bureaucracy, and so on. So with this approach, shortening 26 minutes in the door to initiation of the procedure, we save a lot of brain tissue, improve outcome, and we try to measure what was the impact on the cost. And we observed that with an investment of 4 million euros, this approach tell us that we were able to save 19 million euros in 10 years for all the stroke patients that we attend here. So it's just for the fact that you transfer the patient directly to the angio suite instead that send the patient to the ER. and see for the neurological evaluation, CT scan, they call the paramedic, call the nurse and transfer the patient to the angio suite. And this is based on our technology, our internal communication. We have a platform called Join, which is a method for internal professional communication that speeds up the process. So this is the value of this process improvement. So
you consider that behavioral economics?
Yeah.
Okay. Thank you.
And you can show this to the manager of the hospital, and it is important to support your applications for grants, for instance. This is our model. So now we try to apply the same model in a different scenario.
Okay, well, let's bring the medical profession in the room again. So, I mean, we see many advances coming from startups, big corporate companies in digital technology for healthcare. I mean, when you go to health summits, you see that the world is changing, but then you go to see a doctor. It's all obsolete technology, often nothing changed. And do you actually think that in the future, the medical profession will change, and how digital transformation is already affecting it for you?
Yes, I think it's not in the future, it's now. It's necessary now, because the doctors that finish their degree, they don't know a lot the different technology that exist. They're thinking about the old system, and the system is changing very quick, and they have to be the ability to think in another way, to think in an holistic way, because they need to know these different technologies, the different way to work in process with lean methodology. I think they need some studies, some knowledge that in the universities now it's not available for them.
I think that what is true for patients is also true for healthcare professionals. They are not only healthcare professionals, they are people, and they are out there using the digital banking, using all the services that are available for them. So what they want is the system to transform itself, to be able to liberate all that potential into their daily work.
Other thoughts? Okay, no, my problem is, like, aren't we asking too much from the doctors at the same time? I mean, already becoming a doctor is pretty hard, and then you have to be an expert of design thinking, lean startup, and also use the data, and then embrace all the digital transformation that is happening in there. Like, how do you, I mean, will you see the doctors collaborate with this technology or be experts in that, or?
Innovation is a process, and as every process, it has different parts. Doctors, in this case, are meant to be one part of that innovation, not all of the parts. We cannot ask them to be experts in their medical field, plus being experts in design thinking and being experts in user interfaces and in big data. Why not? Artificial intelligence and whatever, it's just impossible. So what we need to do is be very careful when designing the processes and making sure that in that innovation process we include their point of view as a part of the process. But we cannot ask practitioners and doctors to cover all of the process. They need to be one part of it. And that process has to be driven by a lead that either comes from, or in the perfect scenario is a lead that combines the needs from the institution and from the potentially private company, let's say, promoting this process. But in every case, every part of the process has to play its part, not all of them, and not further than that. So we need to consider that the practitioners are one part in that process.
I agree. We don't need experts everywhere. And for instance, for time-consuming pathologies like stroke or myocardial infarction, what we need is artificial intelligence programs, algorithms, shortcuts that speed up the process. And you have behind the expert to help the development of this approach, but not at the end of the chain. The chain has to be fast, pragmatical approaches that is like banking. You don't need a banker officer there. You just need, pop. It's like this. It has to be that easy, and always win with that. Absolutely.
Thank you. Any questions from the audience? Okay, yes, please.
Well, I was sorry, but I would like to go back because I was writing the question there, but then if we can jump, I would like to go back to the innovation procurement
Sure.
part. Because here in Catalonia, yes, we strongly believe in public procurement of innovation. In fact, we have a lot of procedures right now ongoing, also open for the SMEs. So it's not something that is just focused on the big companies, and it's something that we are really strongly initiating, not only initiating, but executing. So it's not just an idealization. We are not just writing papers. We are doing them. And in fact, 2 years ago, through the Salut, we launched a program where all the healthcare providers from the Catalonian healthcare system were able to submit the proposal of how to spend money in public procurement for innovation. We have right now 18 public procurement of innovation procedure ongoing. Some already were awarded a contract, some are still defining what are their needs, some other already started their open market consultations, some other they already closed their market consultation. So there is a lot of, we are doing a lot. And in the case of SMEs also, depending on the kind of clearly the kind of procurement of what kind of services we would like to contract. Just to tell, we are talking about 30 million euros, so it's not just in 2 euros. Clearly also there are some specific requirements that we boost the collaboration with SME. And specifically if we contract services like research and development that are pre-commercial procedure, that are exempted by the Public Procurement Directive, and where the research and development is delivered in 3 phases in a way that at the end the public procurers can somehow evaluate the process through the design, through the prototyping, through the testing, and come up then with something that really addresses their needs. And also I would like to suggest something when Eva says we don't have money. That's clearly true, because at the end of the day, these investments are done either by Horizon 2020 in some project, others with what we call Fonds FEDER, I don't know how in English, but by the way, in any case, independently, in the case of Fonds FEDER, then the Department of Health, or the Salut, needs to, or the different healthcare provider needs to co-invest the 50% of what is funded. So in any case, there is a major investment from the health system. And
the question?
no, because my question was, are you aware of all of it? Because I'm concerned that they are saying, yeah, we're not doing anything.
No. I think we didn't at least we didn't mean to say we're not doing enough. What we were I mean, and I think we covered when we spoke here. We covered Horizon 2020. We mentioned the FEDER funds. We mentioned initiatives at a European level, both also at a local level. So I think we mentioned part of it, and I think I speak for my colleagues here as well. We are aware and happy to have all these methods. What we have to do is to improve them. You were mentioning many of these channels. If I ask you about how long it takes for one of these channels to effectively generate an invoice that I can bank, if the answer is, well, around a year, I just cannot play. So I think from my point, and in this case, let me be very pragmatic and very individualistic, and I will talk about the small companies' role here. it's majorly not adapted, simply. But there is a lot of channels in there, and I think it is the point here is actually, okay, let's adapt them. Let's think about how we can make them more tangible for small companies that need this to happen in a period of a month.
Okay, well, I somehow disagree with this perspective.
Great, that's good.
No.
And we can discuss perhaps, I'm sorry to cut it out because we only have like 5 minutes.
I think it's an important point. The same aim is to know that if you play in healthcare, you are playing in a regulatory
Absolutely,
environment. So
absolutely.
in any case you need the certification, in any case you need to prove.
Definitely.
So this time, that's all.
Yeah, we know that regulation.
1 month you can wait.
Definitely. No, we agree on that. The last question, comment from the audience. Oh, you look like you wanted to ask a question, sorry. Okay, let's perhaps take that one. So, coming back to patient engagement, so how is Vall d'Hebron Hospital working on patient engagement? I mean, I think we've answered that partially, but I don't know if you want to add anything on that.
Well, we have a platform called PharmAlarm for patient management, and then we are now developing it's like a social network for patients and professionals, just to encourage them, to motivate them to be part of this process, active part of this process, just including gaming in there, just to try to have a group of people, a different group of people with different risk factors. For instance, patients that are very similar in these groups, for instance, hypertensive, diabetic, and obese patients. They are very similar, at the same age. They have a group centered by a nurse. And all is digital, but the nurse is coordinating the group. So that's what we are working on.
And perhaps a very last question for the whole audience. We've seen from all the presentations that the value chain is really complex. There are way too many actors, and Yulima mentioned the slide with different payers, patients, providers. How do we actually balance the value chain and value-based needs from different stakeholders? Like how you as a procurement partner see your role in there, and basically from the hospital, how do you ensure that the value is present for the whole process, let's say? Hard question, I know.
It is. A lot of there is potentially not a single answer to that question, or not an easy or quick answer, but if you ask me, a big part of the answer to this question is a good design of the process. When we want, and I'm sorry to talk again about the process, but the design of this process involves also to understand what's in stake for all the different parts. What's the benefit and what's the value, which are different things, that each part wants to deliver and accomplish for themselves and for the other parts. So we need to, when we want to achieve a solution, whether it is a product, whether it is a study, whether it is whatever it is, the process to get there, when we understand which parts play in there, and that will be complex because we are in healthcare, that's going to be complex. We need to design the process in a way that we understand and we balance and we also share the value and potential benefits that each part wants to deliver to this process. So it's a part of the answer to this complex question is to design the process properly.
And transparently as well.
And transparently, of course.
Yes, I agree with you. It's very important to make multidisciplinary team with all the stakeholders. It's very important from the beginning. It's necessary because if we want to success with a solution, it's important that all the stakeholders are agree and their value is okay for themselves.
Multidisciplinary team processes.
Another part of the answer to the question perhaps is, as we always say, put the patient on the center. Put the patient in the center, listening to them about what they are thinking about the science that we do. Okay, that's quite important too.
It's important too. Thinking about needs, unmet needs, not solutions. This is very, very important.
Need-driven approaches. Okay, well, with that, perhaps if you have any takeaway for us on the future of value-based procurement after Like any summary from all the discussion that we're having since this morning from each side? Anyone?
Okay, I think there are several challenges in the near future on value-based care. So this just a start at least in our scenario here in Catalonia. We just started in our hospital. We are learning on the way. We are learning a lot. We are learning how to collaborate not only in the public sector but also in the private sector. And we need. I think this is important. Basically, in this discussion to open the door and be more flexible to get the private sector in this process. We have to work together as a team to build the process of care from the beginning. From the beginning, I said rebuilding everything and reset the process and see this is the need in the primary prevention, this is the need in the in-hospital care, this is the need in the secondary prevention, and including also the cost. Cost is an issue, and this is tough to sell this idea that you are going to save blah, blah money in 10 years. But it's true. It's true. And it's good for the patient. And the patient is good. And also the resources are enough to get the process done.
Thank you.
I would love to close with an optimistic remark. I'm a very optimistic guy, and I've been critic in some aspects here. But I definitely want to point out an optimistic thought for the closing here. Things are happening, and that's amazing to see how they happen. But the only way that things happen is that all together we push for them to happen. So, to all of you, any ideas you have, any things you think you can improve, use these channels that we described. Use them to get funds, to get attention, to get whatever you need, to get the access to companies, access to technology. Do it, because it is in our hands to make this happen, to make this innovation happen, and to actually get to that goal where our healthcare actually is at the level where we want it to be, is at the value, is procuring value for our patients, and is actually where we want it to be. It's in our hands. So yeah, I definitely always want to close with this optimistic remark.
It's always good. Julio?
Or saying with other words, I think that the change is not only something that we must force, we must work. Of course, we must work quite hard in order to change things, transform the system, but change is unstoppable in really. So you can join it or keep out of its way, okay? but it's something that is going to come. And if we don't transform the system in order to adapt to this change, other people, other companies, perhaps coming from other countries, will come and will change it.
Amazing.
I think we have to collaborate. Public, private, it's necessary because our common objective is the patient. And this is important, and we need to collaborate.
Collaborating with a patient in the center
Exactly,
is really important.
and with the patient.
With that, I would like to thank you, our amazing panel. I think we've got really great insights, and Susan is going to close it just in a minute, but let's... Thank you so much.
Thank you.
So with that, I pass the stage to Susan to talk about takeaways on basically what's happening next for value-based healthcare.
Thank you, Olga, for really doing a great job moderating, and thank you, the panel. Well, you said it all. I mean, I think I just want to highlight three, but I invite the audience. You may have your own take-homes, but what is value? Outcomes that matter to the patient. But those patient expectations are changing. And I thought that was really powerful that you were talking about. And this is a really great one. Value that's buried in the data and in mixing, the potential of mixing this untapped potential that I think a lot of people are talking about, real-world evidence and these other markers that we're picking up from all of the devices. So it's really an untapped potential that we're looking at. And I would resonate this discussion. I've been in Helsinki, I was in Denmark at a couple of different conferences. GDPR. Everyone is talking about it. I think it's actually going to be, once we get past that gate and we can figure out how to make it more concrete. I saw some wonderful solutions coming out of Canada where they were, putting together some very pictorial ways of how levels of people, levels of access that people could give to their data. I think that's the next big debate that's going to open the door for everything else. And I think everyone mentioning that, it's on everyone's mind. And then patient engagement. The multidisciplinary team that's surrounding the patient at the center and the processes and really putting the patient at the center. So I thought that those were the messages that really, really came through, that we want to hear and see the patient, as you said, and we need to have that dialogue in this very, very complex ecosystem. So I think you all said it really well, and I think it was a great panel discussion, and I hope everyone enjoyed it. What I would just a little pitch in there, the handout on the back page, when we want to talk about funding and getting the money, show me the money. On the back page, there's a list of Horizon 2020 calls. So there's additional funding on those calls that's given in Australia. So those topics, if you're in consortia or interested in those, we're just mentioning them because SMEs are going to be involved in those, as well as healthcare providers and other players. But there's personalized medicine and other topics. We actually won one where there is researchers in Australia are going to be working with a consortia in Europe on some projects. So happy to talk about, if you see any of those that are of interest for your companies, give us a call, because we're in touch with a lot of organizations that are going to be working on those international bids. That's my last pitch. So thank you so much, and thank you, Vall d'Hebron. Thank you for everyone and our speakers. I think it was a lively, and so have a great afternoon, and thanks for taking time to come here.